Greetings, everyone. This is Miss Gibson. So, this lecture is also part of Lecture 1. It is going over hematologic cancers. The first one that we're going to go over is leukemia. Leukemia is the name given to a group of malignant diseases of the bone marrow and the lymphatic system. Leukemia is the most common malignancy of childhood and is more common in boys than in girls, with an incident peak between the ages of 2 and 6. It is, however, one of the forms of cancer for which survival rates have improved. Among children with acute lymphoid leukemia, or ALL, the 10-year rate of survival is now 90%, and that is according to St. Jude Children's Research Hospital. So, with leukemia, this is a cancer that results from a loss of normal cellular regulation, leading to uncontrolled production of immature white blood counts in the bone marrow. The bone marrow is then overcrowded with immature or blast cells. They are non-functional cells. The production of normal blood cells is greatly decreased. It can be acute, which is sudden onset. It worsens much quicker for the acute, or it could be chronic, slow onset with symptoms that persist for years and worsen slowly. Your leukemias are classified by cell type. You have a lymphocytic, or sometimes you might hear it called lymphoblastic. This is leukemia cells that come from the lymphoid pathway. You could also have myelocytic. This is cells that come from the myeloid pathway, referred to as APL, acute promyelocytic leukemia. There are some subtypes. They're classified by degree of maturity of abnormal cells and the specific cell type that's involved. Leukemia most often occurs in the stem cells or early precursor lymphocyte cells. Once the leukemia begins, it leads to anemia, thrombocytopenia, and leukopenia. Cells can also be found in the spleen, liver, lymph nodes, and central nervous system. Acute leukemia progresses to death from infection or hemorrhage without treatment. Chronic leukemia may be present for years before changes appear. Acute leukemia progresses to death from infection or hemorrhage. Exact cause is unknown. Risk factors may include ionizing radiation, viral infection, exposure to chemicals and drugs, immunity factors, environmental factors, genetic factors. Leukemia is 3 to 4% of all new cancer cases and 4 to 5% of cancer deaths, and that is as of 2017. The next slide we're going to go over is classifications of leukemia types. So the first one is acute myelogenous leukemia, or AML. This is the most common type. It accounts for about 10,000 new cases each year. It occurs in both adults as well as children. It is considered fast-growing. It has 8 different subtypes. In this cancer, the bone marrow stem cells develop into an abnormal white blood cell called a myeloblast, which does not mature into healthy white blood cells. These myeloblasts are unable to do the usual work of white blood cells and build up in the blood and bone marrow, making less room for healthy white blood cells, red blood cells, as well as platelets. This may lead to infection, anemia, and can cause easy bleeding. Next, you have acute promyelocytic leukemia, or APL. This is a subtype of AML. It is the most curable form. Next, you have acute lymphocytic leukemia, or ALL. This is where too many stem cells develop into a type of white blood cell called a lymphocyte. These lymphocytes are not able to fight infection very well, which causes, of course, an increase in infection. Then you have chronic myelogenous leukemia, or CML. This is a chronic, slowly progressing blood and bone marrow disease. Usually involves a genetic mutation known as the Philadelphia chromosome. Usually occurs in middle age, rarely occurs in children. Too many stem cells develop into granulocytes. And over time, these granulocytes crowd out the red blood cells and platelets in the blood. So there's way too many granulocytes. Then you have chronic lymphocytic leukemia, CLL. This is the most common chronic leukemia in adults. There's too many lymphocytes, and the lymphocytes can't fight infection very well. Last is biphenotypic leukemia. It is a acute leukemia with lymphocytic and myelocytic features, and it is less common. So now we're going to go on into our assessment. So some of the clinical manifestations that you might see with a patient is anemia with pallor, fatigue. It's often severe. Often the first symptoms of leukemia is that anemia and fatigue. Other signs are leukopenia, fever, infection, thrombocytopenia, bleeding, bruising, petechiae. Blast cells also may invade bones, which results in bone and joint pain, limping, could also cause some edema. Bone fractures are the result of the weakening of the bone caused by infiltration of the bone marrow by leukocytes. You could have some hepatosplenomegaly, enlargement of lymph nodes, could also be present at diagnosis. Involvement of the central nervous system is secondary to leukemic infiltration, which sometimes causes increased intracranial pressure. So the first thing with your assessment, you're going to start with age, occupation, previous illness, any exposure to ionizing radiation or drugs, any changes in their immunity. You want to question frequency, severity of infections, colds, unexplained fevers, any changes in clotting factors. Are they bleeding easy? Do they bruise easy? Do they have a lot of nosebleeds or hematuria? You're going to ask about weakness and fatigue, which could be anemia, any behavioral changes, muscle weakness, decreased alertness, decreased attention span, loss of appetite, weight loss. You're going to do a good physical assessment and then also some labs. So your physical assessment is going to start with any cardiovascular changes. Your cardiovascular changes often occur due to reduced perfusion and gas exchange. Their heart rate is going to be increased. Their blood pressure is going to be decreased. They're going to have some orthostatic hypotension. Could be some murmurs, some bruise. Could have some delayed capillary refill. When your white blood cell count is greatly increased, the blood is very viscous, then you'll have an increase in blood pressure, but the pulse will be bounding. Your respiratory changes, this is because of reduced gas exchange. The rate could increase with anemia. If respiratory infection, they'll have cough, dyspnea, abnormal breath sounds. Some skin changes would be related to reduced perfusion. They could have some petechiae, could be all over, but especially legs and feet. That's not related to trauma. Any injury or infection that's failed to heal, bleeding gums or mouth sores that could indicate infection. Intestinal changes, this is related to increased bleeding tendency and fatigue. They could have some nausea, vomiting, weight loss. Anorexia is very common. Examine rectal area for fissures. Test stool for occult blood. They could be constipated due to decreased blood supply to the bowel or decreased peristalsis. Enlarged liver, spleen, so there could be some tenderness upon palpation. Their central nervous system, changes in cranial nerves. They could have a fever, fatigue, cranial nerve problems, headache, optic nerve edema, seizures, coma may even occur. Like I talked about before, they could have some bone and joint tenderness that is due to bone marrow damage. They could also have some enlarged lymph nodes. That is where those leukemic cells invade the lymph nodes. So now we'll talk about lab assessment. Of course, we're going to do an H&H or hemoglobin and hematocrit. We'll do a platelet count, a white blood cell count. The most definitive diagnoses would be a bone marrow aspiration, and then there will also be some imaging. The imaging would be based on signs and symptoms, chest x-ray, of course, for the dyspnea, skeletal x-rays for loss of density and minerals, especially if they're having a lot of bone and joint pain. With your labs, acute leukemia will decrease your hemoglobin and hematocrit. You'll have low platelet counts and abnormal white blood cells. It could be high or low. Your bone marrow aspiration and biopsy, you'll have you can check for protein markers, clotting times, chromosome analysis, blood clotting. You can check for clotting times and PTT are prolonged. And then chromosome analysis may identify markers that aid in diagnoses and type of leukemia. Treatment for acute leukemia, you can do induction therapy. This is intense combination chemotherapy started at diagnoses, attempting rapid complete remission. It does, however, result in severe bone marrow suppression with neutropenia and reduced immunity. So therefore, they're going to be at an increased risk for infection. They will have a prolonged hospitalization while neutropenic. They'll require 2 to 3 weeks for bone marrow recovery. Side effects is nausea, vomiting, diarrhea, alopecia, stomatitis, kidney toxicity, and cardiac toxicity. Next, you could do the consolidation therapy. This is another course of either the same drug used for induction at a different dosage or a different combination of chemotherapy drugs. This needs to be initiated early in remission with an intent to cure. Maybe single round or repeated rounds. May also do stem cell transplantation. Then last, you have maintenance therapy. This may be for months or years. Intent is to maintain remission achieved through induction or consolidation. Not all types of leukemia respond to maintenance therapy. And then some drug therapies for chronic leukemia. You have Gleevec, Spiracel, Tasigna, Rituxan, and then you could also do monoclonal antibodies, which is only approved for CLL. You do need to know that all of those chronic leukemia drug therapies have side effects of low blood counts, headache, diarrhea, muscle, bone pain, fatigue, fever, nausea, and vomiting. And then, of course, if they have an infection, you could do some antibacterial drugs, antivirals, or antifungals. You want to educate on infection prevention, hand washing. They'll be in a private room. HEPA filtration for the immunosuppressed. They'll have daily labs, assess for signs and symptoms of infection, such as on their skin, mucous membranes, lungs, urine. Turn and reposition every 2 hours, and then good hygiene as well as nutrition. Next, we're going to talk about stem cell transplantation. This is an excellent chart here. So, preparation for stem cell harvest with cytokines and growth factors. And then it follows, these steps. So, bone marrow transplant is standard treatment for those who have close matched donor and is in temporary remission after induction therapy. Site of leukemic cell production is difficult to ensure all leukemic cells are eradicated during induction therapy. They may also need additional chemotherapy with or without total body eradication. Must replace bone marrow after this process. Ideally, donor is sibling or matched unrelated donor. The stem cells can also be harvested from umbilical cords of unrelated donors. Let's see. And then with each step, sorry, I keep moving my box. The collection stem cells are collected from the donor's bone marrow or peripheral blood. The bone marrow or blood is processed in the laboratory to isolate, concentrate, and prepare the cells for storage. Stem cells are preserved by freezing at an extremely low temperatures in protective solutions in order to keep cells alive until patient is ready for transplantation. Patients are treated with chemotherapy and or radiation therapy to destroy unwanted cancer cells and develop bone marrow future I'm sorry, and develop bone marrow failure. And then the infusion, this is stem cells are infused into the unhealthy patient. Um, so one big thing that we need to discuss with the stem cell transplantation is prevention of complications. They are at an increased risk of infection. The patient has no protection until the new stem cells take place. They could have poor clotting, failure to engraft. The patient will die unless another transplant with stem cells is successful. And then they could get the graft versus host disease. This is an immunocompetent cells start an immunologic attack against the new cells. And then there's also veno-occlusive disease. This is a blockage of liver blood vessels by clotting and inflammation, which just causes phlebitis. Early detection of that is very important. So now we're going to go into malignant lymphomas. We'll talk about Hodgkin's lymphoma, non-Hodgkin's lymphoma, and multiple myeloma. So malignant lymphomas, these are cancers of the lymphoid tissue with abnormal overgrowth of lymphocytes. Cancers of committed lymphocytes rather than stem cell precursors, as in leukemia, and the growth of scattered solid tumors throughout the body in lymph tissue, especially lymph nodes and spleen instead of the bone marrow. So with your first one we'll talk about is Hodgkin's lymphoma. This can affect any age. It peaks in teens and young adults, and adults in their 50s to 60s. Uncertain of exact cause. There is a link to viral infections and chemical exposures. Starts in a single lymph node. There is a certain specific cancer cell type that's called the Reed-Sternberg cell. It does spread predictably from one group of lymph nodes to the next. Some of your assessment findings: large, painless lymph nodes or lymph node or nodes, fevers, heavy night sweats, and unexplained weight loss. Infection with the Epstein-Barr virus is a risk factor for developing Hodgkin's lymphoma. The most common sites for Hodgkin's lymphoma to develop are in the chest, the neck, and under the arms and groin. Lymph node biopsy helps determine the presence of Reed-Sternberg cells, an abnormal type of B lymphocyte that is this is the main diagnostic feature of Hodgkin's lymphoma. Of course, we're going to do a good history and physical. We're going to do some lab work, an ESR, bone marrow aspiration. There could be a CT ordered of the neck, chest, abdomen, or pelvis, or a PET scan. The PET scans, this assesses for diseases that's not detected by CT. With the PET or the PET scan, the patient will be scanned head to toe, and if there is cancer, certain areas where the cancer exists will light up on the PET scan. As far as Staging. There are different stages. Move my box so you guys can actually see this. Stage 1 is localized disease. You have a single lymph node or single organ. Stage 2, you have 2 or more lymph nodes. Stage 3 is 2 or more lymph node regions above or below the diaphragm. And then stage 4 is widespread, multiple organs with or without lymph node involvement. This is one of the most treatable types of cancer. Nursing management focuses on acute side effects, increased risk of infection, anemia, bleeding, severe nausea and vomiting. They could have skin problems at the radiation sites, constipation or diarrhea, permanent sterility for males receiving radiation in lower abdomen or pelvic region. There is an option to store sperm before treatment, and then risk for secondary cancer development, which requires long-term follow-up. Next, we have non-Hodgkin's lymphoma. There is no Reed-Sternberg cells present. There'll be swelling, pain. Diagnosis is, of course, through biopsy. You're checking for that Reed-Sternberg cell. There's over 60 subtypes. It generally spreads in less orderly fashion than the Hodgkin's lymphoma. The non-Hodgkin's is more common in men and older adults. Once again, the exact cause is unknown. There is a higher incidence with solid organ transplant, immunosuppressed drug therapy, HIV patients, chronic H. pylori and E. Epstein-Barr virus, increase with exposure to pesticides, insecticides, and dust. It is classified and managed based on the subtype. Like I said, there's 60 different subtypes. Some symptoms of the non-Hodgkin's lymphoma. You'll have swollen lymph nodes or the tumor that'll spread to other organs. Painless swelling of the cervical, axillary, groin, or femoral nodes. Diagnosis is with biopsy. Classification will be B cell or T cell lymphomas. And then your interventions with this will be chemotherapy, monoclonal antibodies, localized radiation, stem cell transplantation, are all interventions that you might try or that you might see that gets ordered by your physician or their primary care. Last but not least is multiple myeloma. This is a cancer of the white blood cells that involves a mature B lymphocyte called a plasma cell, which secretes antibodies. These cells are overgrown in the bone marrow. Once they become cancerous, they produce excessive antibodies and gamma globins. This is called gammopathy. GAMMOPATHY. You also have overproduction of melanoma. Scratch that. You have fewer red blood cells, white blood cells, and platelets, leading to increased risk of infection and bleeding because of the overproduction of myeloma. Without treatment, progressive bone loss, bleeding problems, kidney failure, reduced immunity, and death can occur. It's more common in males over the age of 65, American blacks over whites. There is an unknown cause. Some possible risk factors include radiation exposure, chemical exposure, infection with human herpes virus are all put you at an increased risk. So your assessment is going to be a good head-to-toe assessment, evaluation of serum, total protein, blood levels. Are they fatigued? Are they having signs and symptoms of being anemic? Are they complaining of bone pain, or maybe even having bone fractures, recurrent bacterial infections from their immune system being suppressed? The diagnosis is by bone marrow biopsy. 10% of bone marrow infiltrated with plasma cells, presence of myoclonal protein in serum or urine, and presence of osteolytic bone lesions. Those osteolytic bone lesions can show up on a CT scan or a PET scan. Some interventions or medicines might be the proteasome inhibitors. They could also do a bone marrow or stem cell transplant, and then for the bone pain, they would have pain management on board as well. They could also get prescribed immunomodulating drugs. Most of the time, that is given with steroids to help manage the inflammation as well as the pain. That is all for the hematologic cancers. If you have any questions, make sure that you email me. If I have misspoken or confused you, please make sure that you email me. Also, make sure that you go over the different drugs that I spoke of during the lecture. Thank you.